My name is Barbara Burton. I'm a clinical and biochemical geneticist at Northwestern University, where I'm based at the Anna and Robert H. Lurie Children's Hospital in Chicago. My focus has always been on inherited metabolic disease, but I've had a special interest in the MPS disorders over the years, including MPS II. So I have cared for patients with MPS II throughout my career, but more so since we've had available therapies and the care has become more concentrated in specialized centers. MPS II is a lysosomal storage disorder. It's one of the family of conditions referred to as mucopolysaccharidosis. So these disorders share in common the fact that substances called glycosaminoglycans, formerly called mucopolysaccharides, accumulate within the lysosomes of cells in tissues throughout the body. They differ somewhat one from the other based on the specific glycosaminoglycans that accumulate and the clinical manifestations. So in MPS II, we have accumulation of heparan sulfate and dermatan sulfate. MPS II is an X-linked disorder, which means that almost all of our patients are male, although rare females are reported. It's extremely uncommon, but it is possible for a female to be affected. It's a disorder that affects many different organ systems in the body, but exhibits a spectrum of severity. So at the most severe end of the spectrum, we see patients who not only have many somatic features of the disorder, but also have brain involvement with progressive cognitive decline. Those patients may be referred to as having the neuronopathic form of the disorder. And then at the milder end, we see patients that we refer to as having attenuated MPS II because they don't have that progressive cognitive decline. They either have normal brain function or more subtle cognitive and neurocognitive issues, but do not exhibit that progressive decline. But the somatic features can vary in severity in both forms. So we see things like coarsening of the facial features, we see hepatosplenomegaly, we see deposition of glycosaminoglycans on the cardiac valves causing progressive cardiac disease. We see progressive pulmonary and airway disease from GAG deposition in the airways. We also see skeletal manifestations with X-ray findings referred to as dysostosis multiplex and findings in the patient like short stature, progressive joint stiffness and disability, sometimes kyphosis, spinal cord compression. So there's a wide range of clinical features that can be observed. Well, one of the main focuses of a symposium I chaired and also of one of the presentations that I authored has to do with the unmet needs for treatment of somatic manifestations in MPS II. We have had an approved enzyme replacement therapy for MPS II now for almost 20 years, and some patients have undergone hematopoietic stem cell transplantation, but despite having approved therapies that really have been life-altering for many patients and have changed the complexion of the disease, they're not cures, and we still see many unmet needs for improvement in our treatment of the somatic manifestation. One of the things that we did was a systematic literature review looking at unmet needs in MPS II to further define these. And we know from that there are a number of tissues where we continue to see disease progression, either because of inadequacy of our current therapies or late onset of treatment, and that gets us to another issue, which is the need for very early diagnosis and early treatment. But we continue to see patients who have very significant issues with things like airway disease as they get older, with cardiovascular symptoms, with retinal disease. We see a progressive retinopathy and visual loss, and with prominent neuropsychiatric manifestations, particularly in our adults, even patients who are relatively healthy in that attenuated category and may have relatively mild somatic disease, we very frequently see a lot of issues with anxiety and depression. So these are all areas that I think over time we need to focus on. Another unmet need really relates to that need for early diagnosis and treatment, because we know that in MPS II, as is true for so many lysosomal disorders, prevention of manifestations is much easier than reversal once symptoms have occurred, so that we need to really focus on early recognition of the disease, and the best way for sure to achieve that is with newborn screening. Now, fortunately in the United States now, MPS II is on the recommended uniform screening panel, and states are beginning to do newborn screening. I think it's going to develop fairly rapidly across the country, but this is going to allow us the benefit of treating babies from a very early time before some of these severe manifestations have already developed, and undoubtedly will change the outcome of treatment over time. So that's another unmet need. Another need we have really relates to the transition from pediatric to adult care. In the past, before we had treatment, patients with MPS II really very rarely survived into adult life. But now we are able to treat patients in such a way that we have more and more patients entering the adult age group. And of course we need to plan for the transition to adult care, and that means a number of different things. It means helping the patient learn to take responsibility for coordinating their own care, if they're able to do so, and to take that over from parents. But it also means identifying adult providers who can provide care for the patient, both the coordination of care that's often done by a geneticist, but also the subspecialty providers that are so important, because these patients have multi-organ system involvement. They need cardiologists, pulmonologists, ENT specialists, orthopedic surgeons, and our adult colleagues, have had very little exposure to patients with MPS II. It's rare. They haven't survived into the adult age group, and so identifying qualified practitioners for our increasing number of adult patients is a real significant need. And then the other unmet need, I think, really relates to our attention to the burden of the disease, not only on the patient but on the entire family, because caregivers for patients with MPS II can confront so many different challenges. One is just the coordination of all of the medical care that's required, and maybe it's weekly infusions and seeing 8 or 10 different providers, for different types of subspecialty care, physical therapy, other needs that the patient may have. What's the impact of those other family members on their ability to hold down a job, the financial impact, the psychological impact. And, the psychological impact is not only important for the patient who feels, functions, looks different from other patients and other people in the community, and may have difficulty with really socialization and other issues, but also for the family because of the demands of the disease. So we need to address attention to that too. So that's been the focus of a lot of the discussion. Another presentation that I'm involved with here related to MPS II is a presentation of the results of a Delphi consensus process that was carried out through the National MPS Society for the evaluation and management of patients who have a positive newborn screen for MPS II. As MPS II newborn screening is becoming more widespread, we have a need to educate physicians who've not yet seen patients undergoing newborn screening as to how we best make the diagnosis in a screen-positive infant, and also what's the appropriate follow-up once that diagnosis is established. So this is the subject, and we have presented some consensus recommendations related to diagnosis, starting with the laboratory diagnosis of MPS II, where we really feel strongly that although the initial screen is based on enzyme level, we need to follow it up with second-tier testing for GAG accumulation, because of course in MPS II we not only have enzyme deficiency, but we have glycosaminoglycan accumulation, the dermatan sulfate and heparan sulfate, and this helps to distinguish from the very common pseudo-deficiency that we see for the iduronate 2-sulfatase enzyme. We feel like second-tier testing using GAG determinations on the dried blood spot will substantially reduce the false positive rate for newborn screening for MPS II and eliminate the anxiety for families that comes from getting a positive screen, eliminate the demands on the healthcare system of sorting out the pseudo-deficiencies. So that's a very important piece. Now, once we have a patient with a positive screen for MPS II, we need to establish a definitive diagnosis, and that involves both measurement of enzyme activity in a peripheral blood sample and also documentation of GAG accumulation, typically using urine GAGs, and then subsequently molecular testing to identify the variant in the I2S gene. We also have to distinguish MPS II from multiple sulfatase deficiency, where we would also see a deficiency of I2S activity and accumulation of glycosaminoglycans, but where the mutation is in a different gene. So that can be done by measurement of a second sulfatase when the I2S enzyme is measured. Once we have that definitive diagnosis of MPS II, our next task is to try to identify the phenotype. Is this a patient who will have neuronopathic or attenuated disease? And this may be possible by either looking at the phenotype in other affected family members, if there are affected family members, or through the genotype in some cases. Now, one thing that's important with MPS II, because it's an X-linked disorder, is that we do cascade testing in other family members, because we can identify in some cases other affected family members even if there is no positive family history. There may be, for example, affected adult family members who have not yet been diagnosed because they have a mild attenuated phenotype. So it's very important for us to do that, because it not only identifies other patients who may benefit from treatment, but it also helps us to predict the phenotype in the newborn that we're looking at. If we're not able to predict the phenotype either based on family history, other family members, or on the genotype, then we need to follow the patient with periodic cognitive testing to try to identify those patients who have neuronopathic disease, because very likely within the next year or two we will have approved therapies for the brain in MPS II, which are not currently out there but certainly in late stage development. So we will need to know which phenotype we're dealing with. Other recommendations that have come from the Delphi consensus process include recommendations for evaluation of the young infant for the burden of disease across organ systems. So we recommend baseline echocardiography, of course baseline physical exam with assessment of liver size, and then assessment of skeletal disease and other baseline screening tests that are then done periodically as the child is followed over time. For patients who are predicted to have neuronopathic disease, the consensus recommendation is for initiation of enzyme replacement therapy as soon as possible after diagnosis. But we also recommend discussing with families all of the therapeutic options, including hematopoietic stem cell transplantation, what we know about the potential benefits and risks, enzyme replacement therapy, and also, of course, participation in any clinical trials that might be available depending on the specific characteristics of the patient. For patients who are predicted to have attenuated disease with onset in the pediatric age group, we recommend early initiation of enzyme replacement therapy, either at the time of diagnosis or in negotiation with the family over time if there is emergence of clinical disease. In other words, findings on physical exam or on the periodic assessments that are done. Genetic counseling is recommended for all families of infants who are diagnosed with MPS II as a result of newborn screening, and for any other potentially affected family members, since of course this is an X-linked disease. We may have other carriers in the family who are at risk of having affected infants, so we certainly recommend that carrier testing be offered to any such individuals and that they have the benefit of referral for genetic counseling.